Good evening, everyone. My name is Jagdeep Ahluwalia. I'm the founding secretary of the Indo-American Chamber of Commerce of Greater Houston, which I currently serve as executive director. We are a 21-year-old organization. Though the name is Indo-American, we are a very inclusive chamber with a network which crosses all local and international chambers of commerce. We have relationships with the local chambers of commerce in our region, with Indo-American and other chambers across America, with the CII and ISCC in India, and with a network of local organizations in our area. The COVID-19 series has been very, very well received in the community. Thousands of views of our events, both live and the recordings, which are also stored on our website, are being seen across the globe. And as in the past, at today's webinar, we have people who had registered from India, Canada, and the UK joining us on this webinar. And for India, it's a very awkward time of the night, but still we have two people who are very important stakeholders who wanted to be part of it. And many of our friends in India asked for copies. So we are very proud that this is a successful webinar. Today's webinar will be recorded and forwarded to all participants, and we will load it to the Chamber website. We want to thank ICC, the Indian Doctors Association, and Seva International. Seva International is actually streaming today's event, and we want to thank ICC President Jasmeeta Singh, IDA President Dr. Jignesh Shah, and Seva International President Gitesh Desai for all their support. It's now my honor and privilege to introduce the President of the Indo-American Chamber of Commerce, the Chairman of our board, Tarush Anand. Tarush is an attorney by profession. He's a partner at the law firm of Brown Sims, where he practices civil litigation. He has represented a broad range of domestic and international businesses in various types of business disputes across the country. He has received several awards and honors over the years, including an AV preeminent rating from Martingale-Hubbell and selection to the Texas Super Lawyers Rising Stars list for several years. Any questions that you may have, we suggest you type them in the Q&A at the bottom, and we will try to respond to them. With that, I now request the President of the Chamber, Tarush Anand, to make the welcome remarks.
Thank you, Jagdeep, and welcome everyone to the next in our webinar series addressing the COVID-19 situation. It truly is an honor to have with us once again Dr. Vivek Kavadi and Dr. McDevitt join us for this webinar. We did one of these webinars a few weeks ago, and I think it was an incredible webinar, very informative, but with the way this thing goes, a lot of that information is either stale in a day or has become confusing to the average person in a day or two when we get hit with so much different messaging from different sources. And that's where this idea of a follow-up came up, is even with the kind of a network we have with friends who are medical professionals, there's a lot of mixed messaging out there, a lot of conflicting information. And people are trying to go back to work. They're trying to decide what to do with their kids, what to do with their employees from a medical perspective. And people are confused. And frankly, that's an area where we have great resources in the medical community who are agreeing to be here with us today and help us solve these problems and address them head on. So that was the idea for today's event, and from a personal level and a professional level, I certainly look forward to learning about what's next with COVID-19. And so with that, it's my honor and privilege to welcome Dr. Vivek Kavadi, who will moderate today's presentation. As you may recall from other chamber events and our last webinar, Dr. Kavadi is a radiation oncologist here in Houston. He received his medical degree from Harvard Medical School and did his oncology training at MD Anderson. Outside his clinical practice, he's been the regional medical director for Texas Oncology and has been leading their practice here in Houston. He's the incoming Chief Radiation Oncology Officer for US Oncology and was recently named a fellow by the American Society of Radiation Oncology. Beyond being an oncologist, he's been a member of the Chamber, and his connection to the business world continues as he's currently doing his MBA at the Wharton Business School. Please help me welcome Dr. Vivek Kavadi.
Thank you, Tarush, and good afternoon to all of our members. 3 weeks ago, we presented a webinar on the science and medicine behind COVID-19. The pandemic was affecting all of us in our daily lives, both personal and professional, and we were lucky and fortunate to have several members of the top leadership at Baylor College of Medicine, including President Paul Klotman, Deans Peter Hotez and James McDevitt, and Chief Academic Officer Ashok Balasubramaniam, who participated in that webinar. They gave us wonderful presentations on the nature of the coronavirus, the disease incidence and mortality, various treatments, and the status of vaccine development. In today's follow-up to that presentation, we will go in a slightly different direction. And today we're going to talk about what businesses need to do to reopen. Dr. James McDevitt, Senior Vice President and Dean for Clinical Affairs at Baylor, has graciously agreed to join us again to discuss this important topic. As an introduction, I want to take you back to mid-March and describe my world at that time. I was wearing 3 hats. First, as a physician and leader of our cancer centers in Sugar Land and Clear Lake. In that capacity, the questions were, do we stay open? If so, how? And in which capacity? Were we prepared to screen patients and staff in order to keep both safe? Would we have enough staff to do our job? The second hat was as the Regional Director for Texas Oncology in Houston. The questions there were, cancer care is certainly an essential service, but many of the hospitals had directed many cancer surgeries to be deferred. What was that going to do to our surgical practices? Which staff and doctors needed to be quarantined due to potential exposure or having tested positive for coronavirus? Which sites should we temporarily close or consolidate? Which types of patient visits should be deferred, and what could we do with telemedicine? What were we going to do with staff? Some could work from home, but many could not. How were we going to maintain a skilled and valued workforce when revenues were getting slashed? The third hat was as chair of the radiation division at US Oncology. That division has nearly 250 doctors that practice in nearly 150 sites all across the country. We had to advise them on how to keep their departments open during the pandemic. What special cleaning procedures were required? Could we treat COVID positive patients in our facilities, and how would we do so? Which cancer patients could have their treatments pushed back? Can you imagine a world in which we are pushing back cancer treatments? But certainly with the COVID pandemic, we were doing that. What modifications in the treatment regimen could we consider safely? What was happening to our patient volumes? What would be the full effect of the decrease in patients to our practices as a business and our viability for the future? That was in mid-March. This was a new disease and there were many unanswered questions. Everyone was scrambling to come up with plans. Social distancing and stay-at-home orders were part of our new lexicon. Dr. McDevitt and I are both physicians, and we manage healthcare. Our problems are relevant to that industry. However, much of what we face overlaps with so many of your industries, professions, and businesses. Over the last 2 months, we've had to come up with contingencies that evolve rapidly. As we are now in an era of reopening our businesses and our lives, what lessons have we learned? And what should we be doing to appropriately embark on that reintegration? Dr. McDevitt has been leading Baylor's COVID-19 operations, and today he will share his thoughts and guide us on reopening businesses. After his presentation, he and I are going to have what is going to seem like a fireside chat, except this is May in Houston, so there is no fireside at this time of year. So at this point, let's please welcome Dr. James McDevitt, who has graciously once again agreed to participate with us. Dr. McDevitt?
Vivek, thank you very much, and thank you for having me back. Happy to be here. I'm going to spend just a few minutes talking about the current state of the virus in the city of Houston. Not much time, because I want to get to the sort of reopening question. And we went over some of these data before. I'm going to attempt to share my screen with my newly found Zoom presentation skills, which are rapidly evolving. These data are available on the Baylor website. They're generated by the Texas Medical Center. Am I still sharing? Yes. Can you see a graph with the line going up?
Yes, we can.
Yeah. So I meet every day with the CEOs of the TMC and the McKinsey Consulting Group, and we look at the numbers. So if you look at what we were faced with from the very beginning of the crisis. We started meeting back in May of 20. There's sort of been 3 phases from my perspective. One was sort of back here at the very beginning of the thing. when we didn't know what was happening, and the numbers going up, and they're going up at sort of a scary rate. And in this phase, like Vivek just said, we had to think about shutting down, slowing down, canceling elective procedures, kind of slowing our business down, as many of the people in the call also had to do. Again, Baylor is a $2.3 billion operation. Well, in the clinical operation, we lost 70% of our clinical revenue. Just the volume was not there. So, as you were saying, keeping your workforce employed and engaged and feeling safe was the trial in the first part of this. The second part of the challenge was sort of in the middle of this curve, when we were wondering, well, when is this going to end? And are we going to look like Lombardy, Italy? Are we going to be standing over patients that need to be intubated with 3 patients that need to be intubated and only 3 patients, only 1 ventilator? So a ton of work around surge planning, creating a workforce, figuring out how I could safely get doctors that were used to working in an ambulatory setting and maybe taking care of outpatients, moving them into a hospital to take care of patients on ventilators and hospitalized patients. So we developed a lot of training mechanisms to get those doctors feeling safe, and also a lot of work to figure out how to take care of our workforce during a difficult transition. We're kind of through that now. So and hats off to Houston. I think social distancing clearly worked. There's just absolutely no question about it. We were headed for a really bad place. And now we're starting to loosen up, and hopefully we maintain this sort of steady equilibrium of cases. So what you're looking at here is, on a day-to-day basis, the new cases from Houston and the surrounding 9-county area. So we're really comfortable when the case rate is below 200. As you can see, on the 11th, it was down close to 100, but then it went right back up again. Now, that's probably a data issue. I think that's probably about 200 cases average in the course of a day, but this has been pretty flat. And this is a number I look at closely every day to see what's happening as we start to relax our social distancing. I think even a more important number for me now, the first slide is all the patients that are being tested in the city of Houston, all the people that are positive, including those people that are either asymptomatic or not terribly ill, because a lot of people don't get terribly sick with COVID. That's affected by the number of people getting tested. So as we test more people, that number will go up. What's a better number for me is the second one, which is actually, when you look at the Texas Medical Center hospitals, the number of people that are actually admitted to a hospital, which is hard to fake. If you come into the hospital because you're sick. And as of the 12th, only 19 patients came in, and I think that's a pretty clearly convincing downward trend. So again, look at that very carefully. Hope that continues. Lots of ICU capacity, and just if you're keeping a score of what's going on in our community, we've hospitalized now 2,700 people with COVID. There's still 400 people in the hospital, and about 256 people have passed away. So that's the number story that I, again, don't necessarily want to focus on right now. And I will get to the main part of my presentation. So I'm going to talk about reopening strategies. And before I do, if you go to the Baylor website, you can download this PDF I'm going to show you. So it's available if you just go to bcm.edu, which is the Baylor website. That's the main splash page. And you'll see right at the beginning something that says coronavirus response. Click on that. It takes you to a page with a lot of information about COVID-19. But specific to this conversation, you'll see the sign Baylor offers guide for reopening businesses. If you click on that link, that will bring up exactly the presentation I'm going to go through today. So if you want to download that for your reference, you're certainly welcome to. So I will move into the presentation. Yeah, so reopening business. And how did we come to put this little presentation together? We have struggled the same way all of you on the call have struggled to think about how do we maintain a viable business, how do we keep our employees safe, how do we balance the priority to lockdown to protect our healthcare system and prevent the spread of the virus with the economic reality that we really have to get the economy moving again. So we started thinking about how we do that at Baylor. So part of this is the experience of the past 9 weeks of living this and having to function in an environment where we didn't have the ability to shut down. We had to keep taking care of sick patients, but do so in a safe way. And then part of it is informed by the luxury I have is I have a lot of really smart people running on Baylor that are infectious disease experts and epidemiologists and infection control people that have helped us to formulate some strategies. And I will talk about those and also touch on some testing guidelines. So again, walking through, I'm not going to read you every slide, but I'll go through some of the highlights. In terms of dealing with employees, and everybody on this call has, I'm sure, already wrestled with all these things and probably have come up with some better ideas than we have. But clearly managing your employees and the spacing of your employees and maintaining appropriate social distancing in the work environment is really critically important. The magic 6 foot number that everybody is focused on, 6 feet now, excuse me. There we go. Critically important to maintain social distancing, and some things to think about that you might not is you have employees that are safe and happy and doing a great job when they're out on the showroom floor, but they get back into the break room and suddenly social distancing goes out the window. I can tell you at Baylor today in a break room, we saw people that were going back in the break room, sitting around little 4x4 tables, masks off. So look for those areas in your business where those at-risk areas are, where people are likely to break social distancing. I think that's critical to walk your area. At Baylor, sort of a unique thing is our auditoriums is a sort of a special place that we have to be concerned about. So in our auditoria, we went and marked with red and green dots those chairs that you can sit in, those chairs that you can't. So we feel like we're appropriately socially distanced in those environments. So spacing out seating, thinking about staggering of start times. When you have a bunch of employees show up at the same time and they tend to aggregate at the entryways, one way you can avoid that is to have everybody show up on 15-minute increments. And then critically important, I think really critically important, maybe one of the most important things I'll say, is making sure that you have good policies to get people to stay home if they're sick. The last thing we want is for people to show up and infect other people and infect your employees. The supplies, no magic here. I would highlight something that I see quite a bit around Houston is the use of gloves. And gloves are a little bit tricky because I have been waited on by waiters before. They're wearing gloves, and it makes me a little bit nervous because gloves don't really keep you safe, and they don't really keep you clean. If I touch someone with my gloves and I touch somebody else with my gloves, I'm contaminated. So unless you're changing your gloves frequently, they don't really afford you any protection. I would rather be waited on by somebody who's washing their hands regularly than somebody that is wearing gloves. Think about your approach to your visitors and also your supply chain, your vendors in your business. I mean, who's coming in? You can do a great job with social distancing with your employees, but what about the FedEx guy that delivers your supplies on a regular basis? And we try and treat our suppliers like we do everybody else in the organization. They come in, they're screened, they're symptom screened, we shoot their temperature, we make sure they're asymptomatic before they come in, everybody's masked. Also think about traffic flow. So a number of places we have doors to come in and doors to go out so people aren't passing each other. I've been in some businesses in Houston now where there's one-way traffic flow in aisles so people don't pass each other. So I think that's another really good strategy. Think about how you're managing deliveries when people show up at your doorstep, and you've done a great job with all your employees. The I've been at restaurants in Houston that leave their food outside and they go back inside and have really paid a lot of scrupulous attention to social distancing. Just think about how those packages are transmitted. The DoorDash, when they drop off your food at your door, there are a lot of no-touch mechanisms for DoorDash now and other delivery services. The facilities, in terms of keeping your facilities clean, in managing your facilities, talked about some of these things already. I pay particular attention to elevators. If you put, it depends on the size of the elevator, but there's no elevator that you can get more than 4 people in that's going to be safe. And in most of the elevators at Baylor, it's 2 people. So measure your elevators and make sure that you're able to maintain appropriate social distancing in elevators. Cleaning is not, everybody focuses on it and it's important, but it's not particularly difficult. Cleaning and disinfecting is generally done with normal products. Non-porous surfaces you clean with disinfectants, and there are a ton of them, and they almost all kill the COVID virus. Soft surfaces you would clean as you would any other soft surfaces. If you're laundering things, you can launder them normally. That's effective. On the website, if you click on this link, you'll get to a list of approved products that will actually kill the COVID-19 virus, but it is most commercial products. And then a couple of numbers to keep in mind. 1 hour is important. If you have somebody who is COVID positive in a room, it takes about 1 hour for droplets to settle. So you can leave the room alone. This is important in the clinical setting. Let the droplets settle and then go into clean. 1 week, the virus is generally dead. So if you're in a room that has been empty for the past week, and this is for a room that's been exposed to COVID, generally you don't need to do any kind of special cleaning after a week. We took a pass at thinking about different businesses and all the steps that you should be thinking about: masking, social distancing, employee policies, which I'll go over in just a second, cleaning, et cetera. If you're a retail business versus a gym, how are you different? Well, in a gym, it's maybe a little difficult to require masking of patrons in a gym. I don't think most people like to exercise with a mask, which means you might have to pay more scrupulous attention to social distancing. Maybe you need to keep people 12 feet apart instead of 6 feet apart. But think about it as a business. Can you offer to-go options? Can you consider some other way of delivering your service? Everything I do now is Zoom. I haven't seen a live person in the past 6 weeks. Something I see that is sometimes missed is, I mean, you want to keep your employees safe, but you also want to make people feel real safe in your environment. And I think a good rule of thumb, if you're walking into a business and it feels pre-COVID, it feels like it's business as usual, it feels like nothing is different, you're probably not doing it right. And I go so far as to say you probably should leave that business because it should feel different. There should be active things that you do to maintain social distancing. So does your environment feel different to consumers? I think people pick up on that and they appreciate it when they see that you're doing something to help. We've also created patient-facing communication to communicate to people how we're keeping them safe. And I think as a best practice as a business, you should probably communicate to your patrons what you are doing as a business to keep them safe. A big part of reopening and regaining people's is regaining people's trust and getting them comfortable to come back to our organization. We try to build and reopen around Baylor by making it the safest place that you could possibly come. I'm going to spend a little bit of time on the next couple of slides because this is where a lot of the meat is. But we've spent quite a bit of time thinking about what happens when you have somebody who is exposed. They've either been exposed to somebody with COVID-19 or they actually are diagnosed with COVID-19. Can they work? What do you do with them? And I think we've had the advantage of being able to work through this with a pretty good degree of familiarity with CDC guidelines and with, as I said, a lot of ID and epidemiology folks that can help to walk us through the use cases. But if you're in a non-medical business with an HR department or not, I think it's something you probably struggle with. What happens when somebody's exposed to COVID-19? So this is sort of our guidelines. This is exactly the way we manage employee exposures at the Baylor College of Medicine. And I'll again, walking through this row by row. In terms of symptoms, these are the CDC symptoms. We update this regularly because the symptoms actually have changed fairly regularly over the past few weeks. But if you have cough, have shortness of breath, or two of any of these other symptoms, including recently they've added loss of taste or smell, or shaking chills. Well, if you're symptomatic, should I work? The answer to that question is no. As soon as somebody is symptomatic, they should not be in your workplace. Should they stay home? Yes. Should they self-quarantine? Yes. I'm going to talk about self-quarantining in just a minute. The face mask is sort of a moot point at this point because everybody should be wearing a face mask. In the next two columns here, should I contact my primary care physician and when can I come back to work? Make sure that you recognize that as a company, you have an obligation to manage things from an HR perspective and a safety perspective, and people have medical needs, and don't confuse the two. So should I contact my primary care physician? That decision is driven by whether your employee is sick or not. If they're sick, they should see a primary care doctor. They should not go to the emergency room. They should, unless it is truly an emergency where they have to call 911 and they're really that critically ill. But by and large, they should be contacting their primary care physician. Most primary care physicians have a mechanism now of assessing people for COVID-19 without physically coming into the office, and they can get tested. So contact your primary care physician if you're sick. In terms of when should you come back to work, I'm going to cover that in the next slide, but that is an internal policy that, again, can be based on testing or can be based on symptoms, and that's really your internal HR policy. Second, I think this is an important point. There are symptoms that are not consistent with COVID-19 and you can work. So do I have allergies? And I've got the same allergies I've had every year in Houston for the past 15 years, and they're relieved by my usual allergy medication, and I'm sneezing. Well, that's not COVID-19. So yes, you can work. Yes, you should wear a mask because everybody should be wearing a mask. No, you probably don't need to see a doctor unless you're sick. And there aren't any HR implications for that. So I think that's important that we're not needlessly sending people home. Have you traveled anywhere? And this anywhere changes, so it's footnoted. Right now it's outside of the US, and the governor has identified a number of places around the US that require 14-day quarantine upon return. This is compliant internationally with CDC guidelines and nationally it's consistent with the governor's guidelines that you just can't work. You're subject to a state mandated quarantine for 14 days. So the answer to that question is, should you work? No. Should you see a primary care doctor? Well, no, not really, because you're not sick. And there's really not any decision to make from an HR perspective. And then lastly, have you actually been diagnosed with COVID-19? You've had the diagnostic test, which I'll talk about in more detail in just a second. It is positive. Well, obviously you shouldn't work. Yes, stay home. Yes, wear a mask. Doctor if you're sick, and company protocol, which I'll now cover in a future slide. Home quarantine instructions. So we tell people go home and quarantine. Again, won't read all these to you, but separate from other people in the house, separate bedroom, separate bathroom if possible. Don't share dishes, utensils, bedding, et cetera, separate laundry. Just maintaining very scrupulous distancing if you are infected in the household, especially if you've got somebody that is immunosuppressed or in a high-risk group at home. I spend a little bit of time on this slide and preface this by talking about testing because it's obviously been in the news repetitively. The failure of testing early on in this pandemic, and more recently, the importance of testing in returning to work. So I will talk both about the diagnostic testing and the antibody testing, two different things. I'll do the antibody testing first. When you're exposed to a virus, your body recognizes the virus. It responds by creating antibodies, both IgM and IgG, that fight the virus off and also give your body some memory. So when it's exposed to the virus again, it gets a head start and it's able to defend itself. So when you develop antibodies, it's a very clear sign that you have already been exposed to the virus. So there's been thinking out there that if we tested everybody and we knew who was exposed to the virus, that it would be easier to get them back to work because we know they're already exposed. Well, in Baylor's view right now, we are not using antibody testing for return to work decisions or to support our return to work strategy. And there are mainly three reasons for that. One is there are a ton of antibody tests out there, and a number of them are very poor quality right now. They just aren't terribly accurate tests. Second issue is a lot of these tests have cross-reactivity with other viruses other than COVID-19, including the common cold virus. So because there's cross-reactivity, you will often get a lot of false positive results that would falsely lead you to think somebody might be immune because they cross-react with another virus. And lastly, the significance of having antibodies in this particular disease is not known. So if you have antibodies, I cannot tell you you could not be exposed and infected with the virus a second time. So this will ultimately be useful. It's not ready for prime time. Baylor is working on a validated test that addresses all those three options. I think that'll be ready in the next couple of weeks. And we may change our thinking on this as the science evolves. So that's the antibody test. The diagnostic testing, or the PCR testing, again, Baylor, we did screening at St. Luke's Hospital. We've now screened in high-risk environments, anesthesiologists intubating patients, people working in the intensive care unit, places where you would think they would be at very high risk of being infected with the coronavirus. We've tested over 500 people. We've had 2 come back positive, and those 2 we think were probably community acquired. So that's a cohort where you would think they would be at high risk of getting the virus, very, very low prevalence. So I think there's very limited utility in testing large numbers of asymptomatic patients at this point. I just don't think it's going to give you much information. And if you did, even if you did, you're just testing one moment in time. So if you could test all your employees next Monday and they were all negative, well, that doesn't tell you what happens to them on Tuesday, Wednesday, Thursday, Friday, when they're still out living in the world and still getting potentially infected. So I don't think there's a role, again, in Baylor's view, for widespread diagnostic testing. And the approach we've taken is we are obviously testing anybody who develops symptoms. We are doing sort of internal contact tracing of close contacts and doing testing people around the people that develop symptoms. And we are testing in our clinic high-risk people. So our ENT doctors that spend all day inserting scopes into people's trachea, that's obviously something where they're going to aerosolize and potentially be exposed to droplets. We're testing about 200 of our providers proactively to see if any of them are positive. Frankly, if that prevalence is low, we will probably back off on even that testing. So we are testing, but we don't have a very ubiquitous testing strategy. I think that's appropriate. As you start to think about returning to work, so I've now been infected, I've been home, how do I decide to come back to work? And there are 2 strategies. One is symptom-based, one is test-based. And these are both perfectly appropriate strategies. The test-based strategy has to do with how long you've had the symptoms. You have to be at least 10 days out from the onset of symptoms. You have to be afebrile for 3 days. Your respiratory symptoms have to be improving for 3 continuous days. And it has to be 14 days total from when the symptoms started. So, and then you have to wear a mask when you come back. So that's a symptom-based strategy, CDC approved and perfectly appropriate. A test-based strategy has the advantage of maybe being a little bit shorter. You can wait until the symptoms resolve and then test. And if you get 2 negative tests, then you are safe to come back to work. When would you use which test, which strategy? We're using a test-based strategy currently. If you had a relatively small organization and you had employees that were difficult to replace, you might be motivated to get them back as quickly as possible and use a test-based strategy. If you had a large organization and if somebody is out for 14 days, you have the workforce to be able to cover for them, you might tend to use a system-based strategy. And then a common question is, well, how do I get tested? Lots of options, and I think to start with, your primary option will be to contact your primary care physician. Every primary care physician has the ability to order the COVID test. It's commercially available, very readily available. The length of time to get the test results back is somewhat variable. It is as quick as a day. The Baylor test happens to be a day. If you're tested in the morning, you get the results back usually that afternoon. Some of the commercial labs are 48 hours, some are as long as 2 weeks. So it just sort of depends on how they process the samples. If you don't have a primary care doctor, you can use a Baylor option. We have a now telehealth strategy. You call that number, 798-3888, or fill out an online form. You can see a physician virtually with a video link, assess your symptoms. We have a collection site that is in a parking garage structure that you come through, never get out of your car, get swabbed, and then the test is run in our lab at Baylor. And generally that morning, we get the results back that afternoon. Tested in the afternoon, you get the results back the following day. If you don't have a primary care physician, I've listed a couple of references to find a primary care physician. These are Baylor related resources, but you could look at the Methodist or Memorial Hermann website, any other website are going to have find a physician tools. These options get less palatable as you go down the list, but you could go to an urgent care and they would be able to take care of you. Again, I would not encourage you to go someplace unless you are ill and need medical attention, because you don't want to go and infect other people. And as a port of last resort, you could be tested by the health department, city or county health department. I've included some references in the guide, and again, we update this deck. So when the CDC guidelines change, we change our deck. Again, it's on our website. You're welcome to look at it as a reference. And we have again a website set up I've already referenced. That concludes my formal remarks. I think we have ample time for questions. I am happy to answer any questions, but appreciate your attention. Appreciate you having me back.
Thank you, Dr. McDevitt. That was wonderful. And as Dr. McDevitt mentioned earlier, the link to his slides is available on the Baylor website. So those of you in business that are trying to come up with a strategy, you can certainly take advantage of that resource. So I've got a couple of questions that I'd like to kick off this conversation with, and then we've got several that have come in from our members. So let's go ahead and get started. The first question is about testing, and I want to make sure that I understood correctly and that our membership understands correctly. With respect to antibody tests, you have raised questions about the accuracy of some of these tests, the potential cross contamination, so to speak, but that's really not the right term, but that the cross
reactivity,
cross reactivity to other viruses that may be similar, but not necessarily COVID-19. And then finally, we don't know what the duration of that immune response is if the antibody test is positive. So based on that information, are you saying that people should not have a false sense of security if their antibody test is positive? Is that a correct statement?
Yeah, I think that's absolutely correct. And to sort of drive that point home, in this environment, I really think you have to treat each and every person you come in contact with as a potential source, either a potential source of infection or somebody that you could potentially infect. So that there is no testing strategy that makes it completely safe to interact with somebody else. So that again, if I get the antibody test and I have antibodies, and it's because I had a cold virus or a standard flu virus, and it gave me a false positive, then I would be running around the community saying, "Well, I'm immune," when I may not be.
Great. And then with respect to the actual virus test, I know that there's a whole slew of them that are out there on the marketplace. Do you have any thoughts about any particular ones that you would recommend, so that if people are trying to figure out where they should go for testing, is the rapid test versus these various commercially available tests? Do you have any guidance on that, or just follow the guidelines of who can get you tested?
Yeah, so there's sort of two main tests. There's a polymerase chain reaction test, which is the gold standard test. That takes about physically 4 to 6 hours to run. That involves taking a nasal swab, extracting the RNA from the virus on that swab, putting it through a machine that replicates the RNA, so you end up with a bigger sample of RNA, and then running it through the polymerase chain reaction, a PCR, which tells you whether or not it matches it against the known viral RNA to tell you whether you get the virus. That's the gold standard. A ton of people are doing that now. Baylor's got a lab. Most of the major hospitals have a lab. The commercial labs in the region have a lab. They're all good. They're all validated. I think they're all reliable. The point of care testing is a little bit more problematic. I think the rate, and it's very much related to flu. Standard flu, there's a PCR test for flu, which is very accurate. And there's an instant flu test that is pretty good if it's positive. If it's positive, you're pretty sure you have flu. But if it's negative, there's a high false negative rate. So you can't be entirely confident with a negative result. I think we're seeing the same sort of thing with point of care testing with COVID-19.
Great, thank you. The next question I had for you was in this concept of the kind of the infectability of an index patient. So in epidemiology and infectious disease, there's a term called R0, and R0, roughly speaking, means if an individual has a disease, how many other individuals can that person potentially infect? So an R0 of 1 means one involved patient will infect one other individual. An R0 of 2 means the involved patient will be infecting 2 other people. And if we're thinking in that thought process, a R0 of 1 means that the disease is stable. An R0 of less than 1 means that it is contracting and we've got good control over it. And an R0 of 2 or above means that this is growing exponentially. So with that background, Dr. McDevitt, would you please comment on the United States approach to reopening? So if we look at what we are hearing, the guidance from the authorities is pretty much all over the map. Most of our members are hearing about other countries' approaches, including Germany and Sweden. And if they are on kind of opposite poles of the reopening, where is the United States? What's our R0? And can you give us a perspective on a governmental approach that is really very much divergent?
Yeah, it's a really good and really important question. So when this thing first started, the R0, the R0 for influenza, I mean typical influenza, is typically about 1, which means if I get the flu, I am likely to infect one other person in normal circumstances. When COVID-19 first hit the U.S., the thinking was that it was between 3 to 5 in that range, which means I'm going to infect three other people. Now, part of that calculation is the nature of the virus and how contagious it is, and how easy it is to spread, and how easy it is to aerosolize and transmit, how far it flies. And then part of it is based on our connectivity and our social distancing. So you can affect that number by being socially distanced. If you never see another human being, you're not going to spread the virus to somebody else. So we effectively, I know because we slowed the viral spread down in Houston, we clearly decreased that R0 value to 1, or so we're not growing the virus right now. Now I fully expect that's going to increase as we start to loosen up social distancing. We will see more virus in the community. I don't think there's any question about it. We will see more. The question about, I mean, how do you reopen? Again, smarter people than I am talk about this all the time. I mean, clearly the best thing from a public health perspective, sort of, would be to lock everybody in their houses and stay isolated until we have a vaccine. I say sort of, because we see incidents of domestic abuse increasing, incidents of depression, suicide, drug abuse, opiate deaths. Staying home and not working and losing your job has a health consequence as well. So that's not a simple decision. And on the other side of the spectrum, to race to reopen the economy and get back to life as it was, I think that's irresponsible too, because again, the way I've described this before is that from an epidemiology perspective, the virus is like a spark in a pile of dry kindling. That one stick goes up, it ignites all the other sticks. all we do with social distancing is sort of spread the sticks around, and so they don't ignite. But as soon as you push them back together again, they will reignite. When we have a virus, then we no longer have a pile of dry kindling. We've got a pile of dry kindling mixed with green sticks, mixed with wet wood, and it just doesn't spread as quickly. So we're going to have to, in my view, reopen thoughtfully, reopen sequentially. So try something, try it for a couple of weeks, look at the numbers, make sure we're not going too far too fast, and then take another baby step forward. The advantage of living in the United States of America is we have New York City and we've got Des Moines, Iowa, and they are wildly different places, different demographics, different population density. So it can't be the same thing everywhere. I think it's got to be driven by community. And frankly, even in the state of Texas doesn't look too good right now. Our numbers are increasing in Texas, but in the Houston metropolitan area, we actually are doing really well. So I think this has to be a local decision. We clearly have to move towards opening businesses, but to do so in a very thoughtful and careful way.
Great. And then last time when you gave your presentation, you showed a schematic on your predictions on when the trough in the business cycle would be and when the recovery would start. And if I remember it correctly, you had mentioned that you anticipated that April and May would be the lowest points. And in June, we would start resuming our activities, and that in September, we would be close to our baseline. 3 weeks have gone by. Certainly, the information continues to evolve. And so one question I had is, does that graph still look similar to you? And one of our members asked, in terms of these current restrictions, how long do you anticipate them lasting? Obviously, I'm asking you crystal ball questions, but what is your data tell you at this moment?
Well, I'll start by telling you the assumption we baked into our own model for our own clinical business, if you will. We have sort of a optimistic scenario and a less optimistic scenario. The optimistic scenario has us rapidly improving to 90% of our pre-COVID-19 volumes by Labor Day, and then recovering the remainder up to 100% of our volume by next April of 2021. Our less optimistic scenario has us recovering by April of 2021, but in more or less a slower, steady pace until we get there. So that's sort of our bookends. Now that's our guess. That guess is in 25 cents would buy you about an eighth of a cup of Starbucks coffee, I guess. But but I think that's a reasonable prediction. I mean, how long do we have social distancing in place? I'm afraid we have it in place until we have a vaccine, because it's, again, as soon as you reignite the population, nobody virtually is immune. I mean, there are 7 million people in the Houston metropolitan area. The overwhelming majority have not been exposed to the virus. So as soon as we start mixing and mingling again, we're going to get another spike.
Gotcha. So one of our members asked, as businesses reopen and employees go back to work, what does that mean with respect to childcare? So schools are obviously out, parents have the kids at home, but is it safe to send them back to childcare? What are you telling your staff?
Well, it's, I guess the answer would have been a month ago, sort of glibly, well, don't worry about it because kids don't get infected. Increasingly, there's a little bit of concern that kids do get infected. I don't think very commonly, but they are developing some post-infectious complications from COVID. So it's a legitimate concern to keep your kids safe. But you have to have I mean, the reality is you're going to have to put your children in childcare if you're going to go back to work. So I think you have to walk it's sort of like I was talking about, a place should feel different when you walk into it. And as a best practice, we should be communicating to our customers how we're keeping them safe. You need to physically walk into a childcare facility, talk to people running it, understand how they're approaching social distancing, understand how they're managing employee exposures. Are they checking everybody's temperature when they come in every day? Are they monitoring for symptoms? Are they getting sick people out of the workplace? If it were my child, I would spend a lot of time getting comfortable with the facility to make sure that they've thought this through fully. And if they're bumbling around and they can't answer your questions, then I'd be really hesitant to leave my child in that facility.
Gotcha. So I promised that this was going to be a practical, business-oriented talk, but I can't but help and slip a medical question. And you just addressed the issue of children getting this disease. And previously, the thought process was that this was a respiratory illness. And now we're hearing that there are multiple non-respiratory manifestations of COVID-19. In the Baylor clinical experience, what can you share with us about the other organ systems that are being affected? And is this a immune-mediated response, or what's going on beyond the respiratory system?
Yeah, so first of all, even the respiratory system, it's not so much the viral infection that causes the terrible lung problems as a tremendous inflammatory response. So your lung just fills up with white cells, and as a result of the inflammation. There's a lot of kidney impact. So renal failure has been very common and less publicized, but in terms of supply chain, markets around the country have run out of dialysis supplies because people have gone into acute renal failure as a complication. The issue in kids is they develop something called Kawasaki's disease, which is a vascular disease that can cause cerebral ischemia and, in extreme cases, stroke. So that's a systemic effect. There are cases where it has produced a Guillain-Barré-like syndrome, which is a nerve syndrome where you lose the insulation of your nerves and become weak. So it appears to have a number of systemic effects that I think it may be some time before we fully understand what all those effects are. I think some of them might show up as late sequelae too. And there's also some suggestion that there are at least some patients that have had some residual cognitive impact after their infection.
What's the current advice for pregnant women with respect to this disease? I've gotten a couple of questions along that line.
So I can answer that question on two levels. I will punt professionally because I'm not sure I'm qualified to answer that because I'm not an OB and I don't advise pregnant women. On the other hand, my daughter is due on June 24th, so I spend my entire life talking to her about delivering her baby. And her great terror is that she'll have to have a home birth because the hospitals will be full and she won't be able to go in and deliver. But the advice that she's been given is to avoid contact with anybody who has the virus or has been exposed to the virus. So she's social distancing scrupulously. I don't think again, this is where I don't know, so don't take this as the gospel. I don't think there's documented birth canal transmission or infection of a child in the birth process. There may be, but I'm not aware of it. Hypothetically, when you look at viral infections in pregnancy, like Zika, for example, which a couple of years ago in Houston was a big concern that we get Zika, which causes microcephaly, failure of the brain to develop. Those tend to be more first trimester issues. So if I were pregnant and concerned about being exposed to a virus, I would be much more concerned being exposed during the early trimesters, and less so as I got further into my pregnancy.
Gotcha. So we're co-sponsoring this event today with the Indian Doctors Association, and a couple of the physicians have asked about the viability of medical practice. I certainly deal with that greatly within our own group, and we made the judgment that our employees were significantly important, not because we're different than other businesses, because employees are important to all businesses, but in our world, the skill set that's required is not easily produced, and there's always a shortage. So we made the decision that we were going to keep all of our employees, and we have not furloughed anybody. Obviously, that is based on some sort of time limits. I don't know that I could confidently make that statement a year from now, but certainly we've taken that approach. Could you provide some guidance on from your perspective, managing a large operation, what guidance can you give to small private practice physicians regarding the viability of their practice?
Yeah, it's a really difficult question, and obviously size and scale matters. And a large organization can typically weather a financial downturn better than a very small organization. And every business is obviously different. The restaurants, for example, don't tend to have excessive cash on hand, so they tend to burn through cash pretty quickly. I think just in terms of management, sort of the concept is cash is king, doing everything you can to preserve cash and reduce expenses. So that was the first thing we did at Baylor, was to halt abruptly any unnecessary expenditures. So no travel, no capital investment. We don't buy anything. We watch every dollar going out the door. And when I say every dollar going out the door, if I was in a small practice, I would be sitting down daily and literally looking at every dollar going out the door, because you have to preserve cash to stay in business. We made a similar decision. Highly skilled workforce, hope that this bounces back quickly, want to hit the ground running to make up for lost time when it does. So we also have not laid off physicians or reduced our workforce. We have some hourly employees that don't have as many hours as they had before. We've tried to repurpose some of those employees to other roles, because we've got a lot of COVID-specific roles now. And the hope is, can you come back later, please? Can you come back later? Un poco más tarde. Sorry. The fervent hope is that we have a V-shaped recovery, that it's my optimistic back to normal business by Labor Day scenario, in which case we'll be okay. If we have the more gradual recovery, then I think we're going to be stretched from a cash flow perspective. So every business is different, but hold on to cash and try and struggle with the dual priority of being responsible, keeping people safe, and opening up as quickly as you can so you can restore your revenue. That's the difficult balance.
Gotcha. Now, many companies are struggling to plan business travel and arrange various meetings. What are your thoughts about those topics? Do you think that in calendar year 2019, we're going to be able to resume travel, or do you think that even if the economy recovers, that people are not going to be in a position to travel for many months?
Again, this is conjecture on my part. My short answer is no. I don't think we're going to be traveling in this calendar year. I don't think we're going to have big national meetings in this calendar year. Could be wrong. And I say that for a couple of reasons. One is we don't know what's going to happen with the virus. There's a school of thought that we'll see a resurgence in the fall. The big country, I think it is likely we're going to see different patterns play out in different geographies. So we might get things under control in Houston and we'll see a surge in Orlando, or vice versa, who knows. But as long as that dynamic is going on, the businesses and organizations aren't going to be willing to send their employees to travel. And I think a number of individuals aren't going to be willing to travel. So even if we said it was okay, I just don't think that businesses and people are going to be ready to travel in this calendar year. And frankly, maybe not until we have a vaccine and this thing is really under control.
Gotcha. And then one final question. You described two scenarios. In both scenarios, the normal point in time became April 2021. In the favorable scenario, you were at 90% at Labor Day. In the unfavorable scenario, you didn't give a percentage, but you said it would be far more gradual. If I was to ask you from a management perspective, if we're looking at June or July, what metric would you be looking at to say that you're on the favorable path or that you're on the unfavorable path?
Yeah, so we're looking at, let me explain this in a little bit of detail. We're looking at face-to-face volume. So we had a set number of people coming into our organization on a daily basis. We know what that number was pre-COVID. That is our volume metric. That is the key thing we're looking at. Post-COVID, we dropped down to about 25% of that volume. So we lost 75% of our volume out of the gate, and we kind of stayed there. Now, fortunately, we were able to spin up telemedicine pretty quickly, so we regained about half our volume through telemedicine, which helped quite a bit. But as we start to reopen, this is our first quote reopening week. Our goal this week is to get up to 50% physical volume, to have half the volume we're used to having. We'll stay there for a couple of weeks, see how things go, walk our lobbies, make sure that everybody feels safe, that we're distancing appropriately, that the virus isn't spinning out of control. And then we will step up to 75% and ultimately 100%. We have a trajectory then that we complete that over the summertime. So by July, we would hope to get up to to regain our volumes. So that's what I'm looking at, is sort of a trajectory between now and the end of the summer of regaining our volume to our pre-COVID state.
Great. That's excellent, and thank you so much. Do you have any final thoughts that you wanted to share? Any communications to our membership and to the community at large? Any final words of advice?
Yeah, I guess, I mean, just maybe a thank you and a plea. I think, I mean, lots of controversial decisions being made, and the fact that we shut down things to the extent that we did. I know a lot of people suffered, and a lot of people are suffering because of that decision. But we really did, I think, dodge a significant bullet. I really do think we would have been in a position where we would have strained the capacity of our health system and been in a serious public health crisis. So thanks to the city of Houston for stepping up and helping. I think it made a world of difference. I think the plea to this group is, you are all leaders in your community. We need to pattern great behavior. And I think we need to hold each other accountable for great behavior. Because, and a quick story, South Korea, great job handling the virus, among the best in the world. They started relaxing. They opened up their nightclubs, I think, last week. They had 54 cases in one day out of nightclubs. And when they did contact tracing, they traced it to one 29-year-old guy who in one night went to 9 nightclubs. And when they looked at his contacts and his contacts, he potentially exposed 5,000 people. So we can do a ton of great work, and it takes one irresponsible person or one irresponsible business to undo the good work that everybody else has done. So we need to hold each other accountable for not keeping our businesses closed, but to open in a responsible way. If you're walking in someplace and it doesn't look right, don't stay in that business, or ideally have a conversation with them and say, you know, this doesn't feel right to me. What are you doing to keep our community safe?
Wonderful words of advice and a great closing thought. Once again, Dr. McDevitt, we are incredibly indebted to you for sharing your time so generously twice, and hopefully we can have a conversation with you again when we're on the other side of this pandemic. But thank you once again, and Jagdeep, let me hand it back to you.
Thank you, Dr. Kavadi and Dr. McDevitt. This really is very, very informative and very beneficial to the community. I remember one of our advisors, Dr. Klotman, in a previous webinar had mentioned that one of the benefits of webinars like this is getting the word out to the community at large. And we are very privileged that we've got leaders from different organizations listening in who will be sharing it with their members. So the great words of wisdom that the two of you are sharing today will be spread not only across our town, but across America and across the world through our webinars, through our connections. I do want to mention one of our members, Gopal Sarjani of Ansh Labs, whose company, his scientists and he are doing great work in antibody tests. So I want to give out a shout out to him. He's a long-term member of the chamber, and I'd be happy to introduce him to the two of you to see if there's any synergy. I do once again want to thank Seva International for doing a live stream of today's event. I want to thank Bhavna for all the great work she does in putting together the webinar for us. And I want to thank the ICC President, Jasmeeta Singh, the IDA President, Jignesh Shah, and the Seva International President, Gitesh Desai, for their support. I would like Bhavna to bring up the slide for our next event, which features County Commissioner Adrian Garcia. And with that, I do want to thank all of you who had taken the time to log in to today's event for making the time to make this worthwhile. Please do send us your questions or your concerns about issues that you think the Chamber should be addressing. We started the series off focusing on the financial needs of the community, blended in with the healthcare needs, and now we'll be talking about sector-specific programs, picking up on energy, for example, because we are the energy capital of the world. So with that, I once again want to thank both Dr. Kavadi and Dr. McDevitt for making the time to join us today. And once again, thank you, everybody. Today's webinar is over. See you on the next one with Commissioner Adrian Garcia. Thank you. Bhavna, the event is over.